Alright, imagine this. You're in the hospital and they attach a little device to your finger that determines your blood oxygen levels. You feel fine. You look at the person beside you and they have dangerously low blood oxygen saturation levels, and everyone's attending to them. You look down at your own oxygen levels and they seem normal, reading 99%. But you feel some shortness of breath and confusion. Your vision goes black and no one notices. This is the reality of many people and was particularly common during COVID.
In hospitals, healthcare professionals use a device called the pulse oximeter to measure oxygen saturation in a patient's blood in a non invasive way. The device typically clips to a patient's fingertip, ear, or toe and uses wavelengths of light to detect the blood oxygen saturation level of a patient.
We assume that the reading on the device is this objective fact about our health. It's unquestionable. But research has shown that pulse oximeters tend to overestimate the blood oxygen levels in patients, specifically that have darker skin tones, because higher melanin in the skin alters the device's absorption of light. This means that for patients with darker skin tones, such as black, Hispanic, South Asian, their blood oxygen saturation might read as normal when it's actually critically low.
Yeah, it's really unsettling when you think about it. The healthcare system is the place where you expect to feel comfort and reassurance when you're dealing with health problems. But for some people, this could not be the case. What makes it even harder from the patient's side is that they stand absolutely helpless because they can't do anything about their skin tone. It's not something they can control, and that is to assume they know about the problem in the first case.
Exactly. A patient could be suffering from life-threateningly low O2 levels and not know it because their pulse oximeter is reading normal. This is a condition known as occult or hidden hypoxia. Studies have shown that Black patients are over 3 times as likely to have these hidden low oxygen levels when compared to white patients, despite this given the okay from their oximeter. This device is deceiving doctors and putting patients with darker skin tones at risk.
Yeah, these little clips are dictating biased outcomes about who gets better care. Studies done in the ICU have shown that Black and Hispanic patients get significantly less supplemental oxygen, like oxygen tanks and such, than white patients, when they had the exact same true oxygen levels.
As you can imagine, many doctors rely on this reading to decide on a course of action for a patient, and hidden hypoxia has been shown to directly cause worse clinical outcomes, higher mortality, and less ICU admissions.
But how did such a straightforward and simple device turn into a full blown racial bias? Well, let's briefly travel back in time to when they were created. When pulse oximeters were first conceived, naturally they had to be calibrated on people to make sure they gave accurate readings, and to make sure the algorithms behind their function were calculating everything properly. The only problem was that the vast majority of people who these machines were calibrated on were weird. Weird is an acronym for Western, educated, industrialized, rich, and democratic populations. More specifically, on people of generally lighter skin tones.
And that brings us back to the present, with the deep racial bias embedded within the very system that determines whether people live or die, one that has been around and known about for decades, yet nothing ever happens.
This is a real and dangerous issue in the healthcare field, and today we'll be delving into some recommendations we have to solve this problem and reduce the racial bias that occurs due to these devices.
One course of action would be to increase inclusivity and equity training in clinicians and purchasing professionals in hospitals. Clinicians would include nurses and doctors, and purchasing professionals are those who order the medical equipment for the hospital, such as hospital administrators. According to a survey conducted by researchers at Johns Hopkins, purchasing professionals are receptive to inclusivity and equity efforts in their purchasing decisions, but were often unable to provide examples of what they do to ensure equity in the equipment they buy. Training for them would include examples of ways medical equipment can cause harm to minority groups, such as how pulse oximeters overestimate blood oxygen saturation in those with darker skin tones. The training would put emphasis on how important inclusive practices should be when looking at medical equipment to purchase, and also provide resources for ways to do this research. The training for both purchasing professionals and clinicians should be done by experts in the field of medical justice and equity. Purchasing professionals also mentioned that their decisions in ordering equipment also rely heavily on clinicians that work in the hospital, and if those clinicians deem equitable function of the equipment to be important. Therefore, we also suggest inclusivity training for clinicians. This training would be similar to the training purchasing professionals would receive, but also include emphasis on not entirely relying on medical equipment that has been shown to show inaccurate results for minority groups, such as pulse oximeters. Clinicians should follow up with further testing and making informed decisions on what information to trust in these situations.
Building on that, another essential course of action towards improving overall equity is by increasing patient awareness about the overall limitations of pulse oximeters. While these devices are generally known to monitor blood oxygen levels, they have been proven occasionally to overestimate oxygen saturation in individuals with darker skin tones. This in turn can delay the recognition of hypoxia and consequently delay timely treatment. For this reason, it is important that all patients are directly informed that these readings may not always produce accurate results. Encouraging patients to pay close attention to their symptoms, such as shortness of breath, fatigue, or dizziness, and to report them alongside device readings can greatly help to reduce the risk of missed or delayed diagnosis. In addition, healthcare institutions and public health agencies should provide clear, accessible educational material that explain these limitations. Manufacturers also have a role to play by including explicit warnings about potential inaccuracies across different skin tones in their product information. By improving transparency and patient education, individuals are better equipped to take an active role in their own care, while clinicians can interpret readings with greater caution. Together, these efforts can support more accurate detection of hypoxia and contribute to more equitable healthcare outcomes.
I would add another important step as well. It's critical to address the devices that are already in use within the healthcare system. Even if future pulse oximeters become more accurate through new regulations, many hospitals still rely on older devices that were designed using limited and non-representative data. This means that bias affecting patients with darker skin tones persists even after reforms. One way to address this would be through structured post-market monitoring programs. There are such existing programs for other devices in real settings. Applied to pulse oximeters, these programs could help assess differences across skin tones. Hospital administrators and purchasing departments would play a key role in this process. They could conduct regular audits of their equipment and replace devices that show biased results, especially in high-risk areas like emergency or intensive care units. At the same time, procurement policies should ensure that new devices are tested across diverse populations. Lastly, hospitals could report performance data to regulatory agencies to improve transparency and accountability. Over time, this approach could reduce disparities in oxygen measurement and improve clinical outcomes across patient groups.
So, in conclusion, this podcast episode is a call to action towards hospitals to have clinicians and purchasing professionals take the time to undergo specific training to be aware and wary of medical devices such as this pulse oximeter that may show inaccurate results for certain minority groups. It also encourages patients to learn about these inclusivity gaps and be aware of their own symptoms so they can advocate for themselves or others if need be. We also encourage hospital purchasing departments to conduct regular audits of their current existing medical devices to ensure they're not showing any biased results.
Now, before we end this podcast, something to think about is if an everyday universally trusted device like the pulse oximeter has carried this hidden biological bias for decades, simply because of a homogeneous calibration data, what other medical algorithms that are present, AI diagnostic tools, or routine hospital sensors currently dictating your care are hiding similar life-threatening blind spots?